I'll be starting with principles of EOLC. So before understanding what is end of life care, we need to understand what is palliative care. As WHO defines it, palliative care is an approach that improves the quality of life of patients, both adults and children, and their families who are facing problems associated with life-threatening illnesses. It prevents and relieves suffering through early identification, corrected assessment and treatment of pain, and recognition and alleviation of problems, which is either physical, psychosocial, or spiritual. Is palliation and hospice the same? No. Mostly, hospice is something that we do at the V end of life, okay? That is towards the very end. And usually, the life expectancy should be less than 6 months. Usually, in palliative care, there is no time limit which is there. But on the treatment goal aspect, both are looking at comfort care and there is no focus on curative treatment, okay? Sometimes in palliation, you can think about both palliative reduction surgeries, okay, palliative chemotherapy, so on and so forth. But majorly, it is looking at comfort care as well, okay. Palliative care can be given both in hospitals, clinics, and home. Hospice, also similar to palliative care, can be given in this above said locations, okay. Services goals, most of them look towards the same. Only palliative care requires some amount of specialist treatment, okay. By and large, hospice would be mostly nursing and allied sciences. Okay, probably some amount of counselors. Okay, psychologists, etc. They are who form the treatment team in a hospice care. Okay, so this is the major difference between palliative care and hospice. In any disease per se, whenever we're talking about palliative care, whenever someone has been screened for a terminal illness like cancer, and the diagnosis of cancer has been made, or any sort of a malignancy with poor outcomes, always there will be some amount of curative treatment which has started in the initial stages. At the same time, there is also search for medical futility. Okay, as time progresses, if the curative care is not working out, the patient can be switched over to palliative care. And when we are doing so, we have to inform both the family and the patient that all possible curative treatments have been given and we are entering towards a phase of medical futility. And in the end, usually we need to understand that patient will succumb to the disease more so faster than ever. And when death comes, it should be in a dignified, pain-free way and not as a sudden surprise. Most of the times after death, the family still will be dealing with the repercussions of the terminal illness. So bereavement care is also necessary. So whenever we are dealing with a terminally ill patient, especially in settings with critically ill patients who come to us in the V end of the disease, we need to be aware of initiation of good practice statements like end of life care. Okay. So what is end of life care? Similar to the definition of palliative care, WHO has also given a definition for end of life care. It is care that helps all those with advanced, progressive, incurable illness to live as well as possible until they die. Okay. Similar points have been raised by two other societies like the National Health Service and the NICE. Okay. So they all focus at advanced, progressive, incurable illness patients wherein they can live as well as they were during the period of death. Okay. So what are the key principles of end of life care? They are person-centered care or patient-centered care, pain and symptom management, communication, holistic approach, quality of life maintenance, family support, multidisciplinary team approach towards end of life, ethical practice, and access to care. Okay, so coming to each part individually, patient-centered care is one of the important things in end of life care. We need to respect the patient's autonomy. All the options available for treating that illness has to be given. Whenever there is futility of care, patient has to be appraised about those issues, okay, so they can take a right decision. If at all the patient has a medical advanced medical directive, that has to be checked and that has to be upheld. Okay, along with medical management, all the other associated things that is personal choices, cultural and religious values have to be upheld. Pain and symptom management is the only thing which can be continued until the time of death. So that has to be always sought after and treated. Okay. So patient usually will be in a state of depression that has to be sorted along with pain because both go hand in hand. Anticipation of other associated symptoms like pulling of secretions, okay, and wound care, etc., nutrition, all of this have to go hand in hand when we are treating a patient in terminal illness. Communication is another important concept of end of life care, wherein clear, honest discussions about the prognosis and outcomes have to be given to the family and the patient. Regular updates as and when things changes have to be given, and you should be sensitizing the patient, and you should be aware of their cultural beliefs as well when we are communicating. Okay, so always a decision making should be an informed one. Okay, and a decision should be made when all the possible choices are given to the individual and the family. Holistic approach is, as I told you, it is not just medicine alone. We have to look at the emotional aspects, spiritual aspects, etc. Both the patient and the family would be thinking about all possible ways to get out of that illness. So if they at all they have some belief, that has to be upheld. Quality of life is very important. Okay, we should not give up on these patients. We should focus on their nutrition, mobilization, okay, and think about rehabilitating these patients as well as much as possible until they succumb to the terminal illness. So quality of life can be improved with family support. So whenever we are talking about family support, it should involve a good care plan. Okay, it should be told about what are the choices that the family have, what do we do about symptom management, okay, and about rehabilitative activities. And in the end, when the patient passes away, even bereavement support should be given to the family, okay, so that they can recuperate the loss of the loved one. So coming to multidisciplinary team approach, this usually starts at the time of initiation of palliation. So curative treatments which are done to reduce the disease burden and medical management should start off, and at the same time when there is approach towards futility, start involving the palliative team at that particular time, so that there is a bridging between the past treating physician to the next particular team. So when this bridge is happening, whenever we come to an understanding of delivery of end of life care, there will be a consensus between all the treating parties involved, wherein we can sit down and discuss it with both the patient and the family, so that we have a clear communication and we can reach an informed consent. Okay, so comprehensive care planning is what is the overall outcome in a multidisciplinary team approach. Coming to ethical practice is again using all the four pillars of ethics of EOLC. Okay, so that is the autonomy, non-maleficence, beneficence, and social justice with dignity. Okay, so access to care, so they should have all the facilities available for a non-terminal ill patient also. Okay, whenever they want to access OPD patient labs, etc. If at all the patient is willing to get any of those services, it should be available. And then the patient and the family should be made aware about other supportive equipments that they would require, and to maintain all of that, if that all a home-based end of life care is being practiced. Okay, so transitioning from a healthcare setting to a home setting, we need to tell them what are the requirements, how to do that, look for red flags, and whenever they might require emergency care, what is the point of care, a number or a contact that they need. All of this should be provided to them. So settings, I told you, it can be home, hospital, hospice, or care home, other nursing care home. All of this is something that is based on infrastructure. You should tell them what is necessary. Okay, so at home is where you need to tell the family as to what are the basic requirements which would be there for the patient at the bedside, so that he gets optimal medical treatment even at home. Okay, so this is just continuity of care which can be done in any of these places. If the patient is extremely sick and the family does not want to continue care at home, they can be moved to a hospital where separate units should be available for end of life implementation, so that if at all things are going bad and the patient passes away, bereavement can be done without any breach in the personal space of the family. The family can always be present at the time of death of the patient, so that that particular breach or the emotional aspect is always addressed. Okay, so hospice and care homes will have separate infrastructure which is required, which is very bare minimum. only focusing at pain relief, okay, and counseling, etc. Okay, so these things are the ones which are usually focused in hospice and care homes. So in end-of-life care policy, which was given by IACCN, there are certain infrastructural requirements for implementation of good end-of-life care practices. Firstly, there should be a written policy in the hospital and everyone should be aware of this policy. Okay, so awareness and implementation should come as an administrative issue and it has to be done by the hospital's administration. Then space and staffing is the next important infrastructural requirement. Dedicated space for initiation or implementation of end of life care should be available so that it does not hamper the routine treatment of other parts of the hospital and it does not occupy critical areas. Okay, so probably if the patient has taken end of life care, we need not waste an ICU bed wherein the patient will be there just for bereavement, etc. Okay, so you will be reducing the family interaction also most of the times, right? So probably will not be able to give as much care as possible to this patient. So if they are moved to an end of life care facility, probably there they can be focused and round the clock services can be given very promptly. Education and training is very much necessary. Most of the doctors do not know about end of life care properly. So staffs like nurses, social workers, counselors, all of them have to be trained about what is end of life care, what to do. Hands-on training and mentorship should be given to them so that they do not have any hiccups while implementing end of life care. Documentation, when the patient and the relatives have understood that the treatment is futile and overall outcomes are very grim, then they have accepted end of life care. There is a structured format which is present, and based on the structured format, consents have to be taken. Additional support which is required is under special supports like your pastoral care department, okay, or any religious practices if the patient's family wants to do, etc. All of this has to be given to the family when they're looking at good end of life implementation. So the infrastructural requirement in summary are policy, space and staff, education and training, documentation, and special support. So what are the principles, which is the ethical principles of end of life care? Autonomy, beneficence, non-maleficence, and social justice, along with dignity. Okay. So autonomy refers to patient's self-determination. That is the patient's own choice to do or not to do. Okay. So the patient has the right to make informed decisions. He can give us advanced directives and we should always respect whatever choice the patient makes. So this encompasses the ethical principle of autonomy. The next important ethical principle is beneficence, wherein we look at promoting the patient's best interest and minimizing the risk and maximizing the potential benefits. Okay, so we should always look at procedures which can do so. Okay, and majorly we should look at the quality of life in the overall outcome. So that part of the treatment is what falls under beneficence. Next is non-maleficence. Non-maleficence usually stands for first do no harm principle. Okay, usually we should avoid any unnecessary suffering and like unnecessary invasive procedures, etc. should be avoided when we all know that ultimately all of these things would be futile, like unnecessary putting the patient on ventilation, unnecessary prolonging ventilation, initiation of renal replacement therapy, etc. Okay, so we know that there is futility of care. Unnecessary prolonging the suffering is not supposed to be done. So that usually falls under non-maleficence. Social justice is an ethical principle which deals with fair distribution of care, equitable access to resources, non-discrimination, equitable treatment, and addresses the healthcare disparities. So this is something like a young patient usually takes precedence over an old ailing elder. Okay, so this is where we have to do justice, give a chance to a patient who has better chances of recovery than compared to a patient who might not make it. Okay, so this is a part of social justice. Autonomy, beneficence, non-maleficence, and social justice are all important, along with the major thing that is dignity. The most important thing in dignity is it maintains the privacy of the patient, it gives emotional support, okay, and the patient will have some self-worth, okay, that should always be maintained. Okay? So the patient should not feel that we are overpowering his decision making or overpowering his autonomy. So all of this is necessary, and these are the ethical principles of end of life care. What is doctrine of double effect? The doctrine of double effect is an ethical principle that addresses situations where an action intended to do good may cause harm. So the core principle is initially an action that causes harm can be morally permissible if the nature of the act is good and morally neutral in itself. The agent's intention is good or aimed at a positive effect. If the good effect outweighs the bad effect in circumstances significant enough to warrant causing the harm, the good effect cannot be achieved without the bad effect. Okay, so to understand it better, okay, it looks like a lot of jargon. Let us take an example. Okay, so consider a terminally ill patient with severe pain. Okay, so when pain, what do we do? The good effect is relieving the pain, right? That is the morally right way to do it. So what do? We use opioids, probably we use morphine. So what is the potential harm in using morphine? It is respiratory depression because of the use of morphine. So there was an unintended respiratory depression which was caused because of morphine, which was primarily given to reduce the pain. So respiratory depression here caused because of morphine is under doctrine of double effect. And if at all any adverse event happens because of this, the physician will not be held liable. Okay. So here the important consideration are it should be able to distinguish between intended and merely foreseen effects. Okay. If you're foreseen some major issue, you should not go ahead and do it. Okay. So it should always weigh the risk and benefit and always try to minimize the adverse effect as much as possible. Okay. So this is about doctrine of double effect. Approach, how do we do that? Firstly, you need to have a informed consent. Okay, and then when you're having an informed consent, a clear decision making capacity should be ascertained. How do we do that? We need to check whether the patient is competent enough to give consent, whether the family is able to understand this. If the patient is competent, usually there will be no issue with cognition. If at all cognition and competence is lost, surrogate decision makers should be looked at. Who are the surrogate decision makers? Unless an advanced medical directive tells who it is, the next of kin is usually taken as surrogate decision surrogate decision maker. Legal guardianship, ethical consulting, all of them can be done when decision maker becomes a difficulty. Okay. Withholding and withdrawing of life treatment is also a part of end of life care. It can be a patient's preference if it is mentioned in advanced medical directives. Whenever they are mentioning about withholding or withdrawing treatment, the repercussions or the risk of doing so should be explained to them, and then the implementation of any such treatment can be done. Overall, what we are looking at withholding and withdrawing of support is whether good quality of life can be maintained. Okay, so ethical principles, family consultations have to always be upheld when we are implementing withholding or withdrawing of life support. Pain management, nutrition, and advanced care planning are also part of good implementation of end of life care. So I told you earlier that is the best thing that we can do is pain management and nutrition. So this has to be continued until the patient passes away. Okay. So this is part of ethical principles as well. And whenever we do all of this, you should have a clear documentation as to what is being done. Okay. So the 6-step approach in end of life processes. What are they? Identify. So what do we identify? When to initiate and in whom to initiate. Okay. Along with that, assess for physical symptoms, non-physical issues like your psychological issues, depression, etc. Look for communication needs. Plan your site of care, whether it is hospital or home. If it is home, what are the anticipatory things that they need? Okay, equipment, drugs, etc. This has to be communicated, documented, and consent should be taken. Then you implement the end of life. Okay, and when you're implementing, you should have a dedicated, support system which is given to the family. Reassess them time and again, and once the patient passes away, give them bereavement support. Okay, and once the bereavement support is all done and your documentation, everything is done, you can reflect upon that particular case to look for any caveats which was present so that we can do a better job in the next patient. Okay, so this is usually the 6-step approach for end of life care processes. So that is identification, assessment, planning, providing end of life care, reassessment of the care given, and reflecting on the caveats which were given. Okay. So what is dying with dignity? It is a concept of good health, a good death. Okay. So usually there should not be prolonging of suffering. good symptom management of pain should be present, okay, and whatever social and spiritual requirements was put forth by the family, that has to be upheld, okay. So usually we all know there is living with dignity, death also should be done with dignity. So coming to points about withdrawal of life support and withholding of life support. What is withdrawal of life support? Withdrawal of life support is considered uh, when the patient's best interest is taken into consideration. Okay, it is to stop or to discontinue ongoing life support in a terminally ill patient in which we feel that treatment is no longer likely to benefit the patient. Okay, on the contrary, it can also cause prolonging of suffering. Okay, and it can also hamper the dignity of the patient. So withdrawal is it's a considered decision when we feel that patient with terminal illness will no longer benefit from the treatment which is given to him, and it can in turn cause harm because of prolonged suffering and loss of dignity. Okay, the following conditions must apply. Usually any patient who has been declared as brain death as per the Transplantation Act, medical prognostication considered based on patient's decision and advanced treatment, and a multidisciplinary consensus has been achieved. Patient or the surrogate has an informed consent or an advanced medical directive telling that they do not want to continue care beyond this. Okay, all of this should be in compliance with the proceedings of the Honorable Supreme Court. Okay, so usually it has to be a legal procedure. Okay, whenever we are thinking of withdrawal of life support. So withholding of life support is, in withdrawal, what is the issue? The patient is already on some life support. Okay, we are removing that life support, we are cessating that life support. And withholding, we are not at all initiating itself. Okay, so whenever we feel that patient is having respiratory distress or acute kidney injury causing a lot of issues, so we might counsel the family for escalation of care. So withholding is like non-escalation of care. Okay, wherein a measure can be put down from the family or the patient after understanding the risk involved, especially in terminally ill patient in whom we know this particular intervention is only going to prolong the suffering and not overall improve the outcome. Okay, so the another important part of all of this is do not resuscitate. This is similar to withholding life support. This is also something that the patient has to give a advanced medical directive about. Okay, especially when we feel that meaningful survival and good quality of life cannot be achieved by cardiopulmonary resuscitation. Okay, so coming to advanced medical directives. So I was talking about withholding, DNR, with withdrawal, all of this I told you about medical directives. So what is a medical directive? A medical directive is a written declaration made by a person with decision-making capacity documenting how they would like to be medically treated or not treated when they lose the capacity to do so. Okay. So, what are the legal framework which is available for implementation of advanced medical directive? Remember, an advanced medical directive is given by a patient with sane mind. Okay, so only that person can give it. Okay, and there is a procedure how they do it. So, what are the things that can be given in that? They can write as to how they want to be treated or how they do not want to be treated. Okay, so it's like telling what all treatment they want and what all treatment they want to hold. Okay, it looks kind of difficult from a medical perspective, but as a autonomy principle, we might have to uphold it. Okay, so coming to the advanced medical directives and living wills, the framework given by this Honorable Supreme Court in 2018 guidelines in Common Cause versus the Union of India, and there was a 2023 modification. Okay, in 2018, what the Supreme Court upheld was the right to life with dignity. Okay, so whenever that is hampered under the Article 21, it can encompass the patient to give advanced medical directives as to how he wants to pass away as well. Okay, so it is legally valid in India and it should follow prescribed formalities. Okay, so in 2023, what was the modification given? there were certain bureaucratic hurdles which were placed, okay? Like the family had to go to a judicial magistrate and then come back to implement this, and this would usually take some time, right? So we wouldn't have time. Time is of the essence when the patient is critical. So these bureaucratic hurdles were removed in January 2023's modification of advanced medical directives from common cause versus Union of India. Okay, so who can give an advanced medical directive? Any adult over the age of 18 years of sound mind and capability of understanding the consequences can give an advanced medical directive. It should be voluntary. It should be executed in a voluntary manner, and it should not be coerced. That is, no one should influence it. So, what are the contents of an advanced medical directive? The advanced medical directive should clearly specify the circumstances under which withholding or withdrawing life sustaining treatment should be done. Okay, so when should we do this? That should be given. Consent for withdrawal of CPR, ventilator, dialysis, and tube feeding. A person should be nominated as a guardian or proxy. Okay, even a friend can be nominated to make healthcare decision when the decision making capacity of the person is lost. Okay, usually this can be revoked, okay, when the patient is felt non-competent. Okay, so competency of the patient will be challenged when he is giving an advanced medical directive. Formalities for execution based on the 2023 Supreme Court guidelines is the AMD should be written, dated, and signed by the person doing so. There is no prescribed format in how he must do it, but it should clearly indicate what are the patient's wishes. It should indicate a nomination of a proxy, and revocation rights also should be given there. Okay, so revocation rights meaning if at all the patient wants to change his decision, when should it be done? That should also be written. And when will it be considered valid? Once the patient gives an AMD, that is an advanced medical directive, okay, nominates his proxy and makes sure what all has to be done. It has to be witnessed and attested by two people. Okay, so this was the bureaucratic hurdle which was removed. Okay, so attestation can be done by any two witnesses, and it has to be countersigned either by a notary or a gazetted officer. Okay, so if this is done in the presence of a notary or a gazetted officer, then an AMD is considered legally valid. Okay, so how do we implement this? Okay, so initially the patient gives an AMD. Firstly, it will be reviewed by the primary medical board. Okay, similar to what we see in end of life decisions. Okay, so primary medical board is again the same. Okay, the doctors, like I'll be discussing in the further slides. So once it is reviewed by the primary medical board and the secondary medical board, if both of them feel that it is legally valid, there is no issues to stop the patient from implementing end of life decisions, then this AMD can be held up and consent implementation can be done. And the whole process has to be documented. Okay, all the medical records whenever the patient has an AMD has to be thoroughly evaluated and then recorded. So it follows a similar principle as we do in end of life care decision. It has to go through the primary medical board, secondary medical board, and finally implemented. So constitution of primary medical board and secondary medical board. So primary medical board is constituted by the hospital or an institution in which there is a primary physician and at least two subject experts who have more than or equal to 5 years experience in that particular subject. Okay, so members of the primary medical board usually should be a multidisciplinary team. Usually they consist of neurologists, intensivists. Okay, so they should broadly be involved with understanding patients with multi-system disorders. Secondary medical board, on the other hand, is constituted by the hospital institution with one registered medical practitioner nominated by the CMO. Okay, so usually along with these people, the nomination of RMP will be done from the state government. Okay, this is the provision of the state, that is to nominate a regional medical practitioner as a CMO. Along with this person, two other subject experts can be present, similar to what we see in primary medical board, who should have an experience of more than or equal to 5 years. So a secondary medical board, a member from the primary medical board cannot be a part of secondary medical board. One doctor should be nominated. He may be from the same hospital or he may be from outside, but this nomination comes from the state. Okay, so along with this, two other doctors should be present. Okay, So there is no bar on all doctors in the boards that can be from the same hospital. Okay, primarily if they're from the same hospital, there is no issue. Okay, if at all it is there, good. If it is not, one person will always be there from outside. Okay. So all of this will be under the purview of the clinical ethics committee of the hospital. Okay, so all of this would be done under the purview of ethics committee. So whenever there is a case, it has to be addressed to the hospital ethical committee. The ethical committee is the one who would have the list of primary medical board and the secondary medical board, and then they will look into the case and implement it. Okay, so how do we implement it? Whenever there is decision for end of life care, there will be a consensus which would be formed by the primary medical board, and once that is reached, it should be sent to the secondary medical board. So once both primary and medical board and secondary medical board have agreed on to it, then we can go ahead and implement end of life decisions. Whenever there is no consensus or no approval either by the primary medical board or the secondary medical board, it can always be subjected to a, a consensus call. Okay, so you can have a meeting with all the parties involved and try to reach an understanding. If at all you're not able to solve this, then it can be appealed to the court, that is your judicial magistrate court of first class or even the high court. Okay, so always there is step one wherein all the parties who are involved, the PMB, that is a primary medical board, and the secondary medical board, or the family, okay, if any of them have an issue with implementation, they can sit, discuss. Only when all the three are in consensus, only then we can go ahead and implement. If any one of them are not in consensus, we cannot implement end of life approach. Okay, so this is about implementation of end of life practices. Thank you.